for Dr. Balaji's Ph.D. Viva Voce. You all know Dr. Balaji is HOD of CSI at New College and one of my first students. And I welcome Dr. Ramki sir, who happened to be my guide also. Thank you, sir, for coming today. And he's done extensively on platelet concentrate, one of the most active the current scenario. That is one of the main part in regeneration. He has done right from in vitro to in vivo analysis. He'll be discussing in detail. The examiners here, Dr. Arpita, she's again one of our students of Meenakshi. She is HOD in Mamta Dental College. And Dr. Snophia Rani, she is a university faculty. I'm handing over the podium to you, Balaji.
Okay, once again, I welcome you all for my PhD thesis. Good morning all, and I am happy here to be presenting my PhD thesis in front of my teacher, my guide also. So, I would like to start off with my Tamil proverb, Mada Pida Guru Deivam. Without these people in my life, I wouldn't have been here what I am today. And luckily, I have my guide also here with me. And with their support only, I completed my MDS until PhD also. I should also thank my guide who given me full freedom in doing my thesis, like right from the first study to till my last study. She literally helped me in each and every part of my study. And as ma'am introduced, I am Dr. V.R. Balaji, currently heading the Department of Periodontics at CSI College of Dental Sciences, Madurai. And a small timeline of my PhD, I joined in 2020 as a scholar, and we have conducted around 8 DC meetings and submitted my synopsis and thesis in 2024. And I summoned Viva today and presented my research at various podiums such as International Research Symposium held last year 2024 and ISDR National Conference and ISP National Conference 2023. Published 6 articles during the course of my study, and we have won first place among PhD scholars in the International Symposium held by Thesis Dental College. Attended more than 23 CDE programs. And as I go through, these are my publications I have done so far. This is the first publication I did immediately after I joined PhD, and these are some of the publications we have done during the course of the study, and I will be discussing it during each study protocol I will be dealing with. So, coming to the actual study, a simple thought that led to this research. What thought? As a clinician, I have seen so many patients. Some patients they recover faster. Some patients take more time to recover. So I thought that what would be the main reason for slowing of that recovery. This led to that why not we use some biological factor which helps in healing. So at that point of time, I thought why not we use platelet-rich fibrin. Platelet-rich fibrin has been extensively used in regenerative procedures. Not extensively studied in antimicrobial efficacy. So why not incorporate antibiotics into platelet-rich fibrin, which will improve healing and control infection. That was my research question at that time. With that, I proposed this title like Antimicrobial Efficacy of Platelet-Rich Fibrin, an in vitro and clinical study. I will let you know each study during the course of my presentation. Before that, a short basics of what is platelet-rich fibrin. We all know blood is a connective tissue. It consists of plasma and cells. Plasma is the most common, it is around 55%, and the cells are around 45%. The most common cells present are RBCs, WBCs, and platelets. And the main ingredient of today's lecture is your platelets. The platelets are of 2 to 5 mm in diameter, and they have a lifespan of 10 days. And what do they contain? They contain alpha granules and dense granules. These alpha granules will contain all the necessary growth factors which are responsible for your healing process, whereas the dense granules consist of main function is to do platelet aggregation, and this is where our antibiotic is going to go and sit. And the main functions of a platelet are fibrin clot formation and the granule secretions are the granule secretions like peptides, which will prolong the action of your platelet rich fibrin, and the role of growth factors. Growth factors are also secreted by the alpha granules, which will help in regeneration. So coming to the platelet concentrates, there are platelet concentrates are of different types. The first one is the platelet rich plasma, which was the first generation platelet concentrate, which we are not going to use nowadays because of usage of bovine thrombin for anticoagulation. So we are going to use only platelet rich fibrin, which is a second generation PC, where it doesn't use a bovine anticoagulant, it uses the patient's own blood. These are various generations I told. We are more concerned today with the second generation of PRF. So what is PRF? It stands for as a second generation platelet concentrate, and it is defined as an autogenous biomaterial which is abundant in leukocytes and platelets, which are derived from the patient's own blood. Actually, it is pioneered by Chokran, we all know that, in 2001, and it consists of a three-dimensional fibrin scaffold, which we call it as a PRF membrane, which will be made into a PRF membrane. This is the actual structure of a PRF, where there will be a fibrin matrix in which you have platelets enclosed. Sometimes you have a lot of leukocytes and some growth factors also. So what are the main properties of PRF? PRF has mainly only three properties, that is angiogenesis, recruiting various cells for regeneration, and for proliferation of those cells. So these are some of the growth factors which are mainly involved in angiogenesis, that is VGF and PDGF for recruitment, and TGF beta for proliferation of those cells. So what are the contents? Basically, it consists of a fibrin clot in the middle and platelet poor plasma on the top, and RBCs at the bottom. Coming to the parts of PRF, the PRF can be divided into three parts, that is the tail part, which is present on the top, and the body at the middle, and the face, which is towards the RBCs. This is another closer version of those three parts. So what are the cells present? I already told you what are all present inside. We have cell types, mainly three cells, WBCs, RBCs and platelets, and we have an intact fibrin matrix which will be holding your biomaterial, and you have the biomolecules like such as growth factors which will be released during the process. So these are the schematic representation of the cell types on the left side and the growth factors on the right side. So these are the growth factors that are present in the PRF, but since the growth factors are not involved in today's study, I am not going to touch about each of the growth factors and its role. We are more concerned with that antibiotic or antimicrobial effect of PRF. So we will be more concentrating on those aspects. So coming to the protocols, there are various protocols for preparation of each PRF. There are different types of PRF, as we all know, from LPRF to AGF, but today's concern is mainly on LPRF and APRF plus. So LPRF is as prescribed by Chokran et al. He told that it should be spun for 2700 RPM for 12 minutes, whereas APRF, it is a low speed centrifugation protocol where you are going to do it for only for 1300, and APRF plus is for lesser time also. APRF is like we are going to do for 14 minutes, whereas APRF plus we are going to go little lesser time. So these are the timeline of preparation of, the identification of those discovery of PRF from PRP to till now it's BioPRF. So coming to the LPRF, what I am going to compare is like LPRF, you all know, like it was prepared by, identified by Chokran. It consists of highest concentration of platelets and highest concentration of growth factors, and approximately more than 65% of leukocytes. Going on to APRF, before going to APRF plus, I will tell you what is APRF. APRF is a low speed centrifugation protocol where the centrifuge, it is centrifuged for 1300 RPM for 14 minutes, and APRF plus is similar RPM, but it's for only 8 minutes. Why we have selected APRF plus and LPRF is like both will have the similar amount of growth factors being released, and the property also is similar. So that's why we are going to compare which will be more effective or efficient. So comparing the different sizes of the cells, you can see here is the RBC, that one on the extreme right is your WBC. You can see the size, it is more bigger than your platelets, and the density is also more with your RBC and WBCs, and platelet has little density compared to other two cells. That's why when you are going to do a centrifuge, the RBCs will settle down at the bottom, the WBCs are above the RBCs, and then your platelets will go into the plasma. So this is the basic armamentarium that is required to collect your PRF. A small video how to collect PRF. So we all know that. So I am skipping. Shall I skip, ma'am? So with these basics of PRF, like how it is being delivered and why I selected these two, and I went into the research. Like first I told you this is my first publication before joining PhD, why I wanted to select this topic. We went into for a systematic review of analysis where they have done any study on antimicrobial efficacy of platelet rich fibrin. There were very limited studies, and only there are a lot of studies which showed more of regenerative potential compared to antimicrobial effect. With this systematic review as a base, and we identified this research gap, that there is lesser evidence for antimicrobial efficacy of platelet other than regenerative potential. So in order to go ahead with my study, I proposed that you should include some antibiotics into the PRF so that it might also enhance that efficacy of PRF also. So my null hypothesis was like PRF does not exhibit significant antimicrobial efficacy, and the alternate hypothesis is like it exhibits significant antimicrobial efficacy. So coming to the aims and objectives, I have 7 studies lined up. First 5 studies are more of an in vitro study, and last 2 will be of more of clinical study. The first one I studied about the knowledge and awareness among practitioners about PRF and its antimicrobial efficacy. Second one, the structural differences. Third one is the main study where it was an antimicrobial. Third one is like compare the antimicrobial properties of LPRF and APRF with and without antibiotics in healthy individuals versus diseased individuals, and also to compare the physical properties of LPRF. That was my 4th study. And 5th study was to compare the degradation time, whether addition of antibiotics interfere with the degradation of the PRF. And 6th and 7th will be one will be your non-surgical periodontal therapy, the another one will be your surgical study. And lastly, my experience with various clinical scenarios where I used PRF with antibiotics. The first study was a questionnaire study. Before going into my PhD thesis, like I wanted to know really there is a research gap between whether the practitioners know the PRF had any antimicrobial effect or they have to use only for regenerative effect. So we divided basically the questions into 4 parts, and we also tested their knowledge and awareness and attitude towards the PRF. And these are some of the questionnaires we were asking, and this was recorded in a Google form. And we found out that most of them knew that it had regenerative potential, but only 20% of people, 26% of people knew that it contained antimicrobial effect, and those people were PGs or periodontists. Other specialty people didn't know their antimicrobial effect. So with this this end of the study, we thought that there is definitely a knowledge gap about antimicrobial effects of PRF. So with this basis, we went on to a SEM analysis. Why we didn't went for SEM analysis is like we want addition of an antibiotic into a biomaterial. Will it affect its structure, or will it affect its regenerative potential or such thing? We are going to see in that scanning electron microscopy. And the hypothesis is the same, does not result in any structural changes, or addition will lead to significant change. But to our surprise, there were addition of antibiotics did not alter any of the structure of the PRF membranes. The platelets were even more evenly distributed in both the groups, and leukocytes were present more and they were dense in APRF group, and the antibiotic group had a thicker fibrin membrane compared to normal LPRF and APRF. And this is the comparison, like the fibers of LPRF membrane were thin and they were strongly polymerized, and the leukocytes are not distributed centrally and they are present more commonly in the buffy coat area, whereas APRF membrane, they were thicker membranes and loosely polymerized, and there were uniform distribution of leukocytes. This is the SEM analysis of LPRF and APRF plus, where you can see a lot of leukocytes present in APRF plus. And with the antibiotics, you can see the density were more in case compared to our plain PRF. This is the antibiotics I tested was on with the amoxicillin, ofloxacin and gentamicin. So with the antibiotics, we noticed that there are thicker fibrin membranes, and during this process of study, we noticed that when we increase the concentration of antibiotics, it definitely impaired the structure of the PRF. So we, based on this study, like also from Pollock et al. Study, we made concentration with around 0.5 ml of antibiotics should be added during the process. With this basis, we all proceeded with the next studies. This is a consultation of all the findings we found. Like PRF with antibiotics, there was an altered distribution of leukocytes, but there were leukocytes. The fibrin density was more, and there was increased platelet entrapment, and the matrix structure was, they had a larger fiber diameter also. And these structural changes with the antibiotics led, we found that it can be used for sustained drug release also. So based on that, we proceeded on with the physical properties of LPRF with and without antibiotics. Here we measured the length and volume of the PRF membrane we obtained. Length measured by a calibrated scale, and volume measured by the calibrated test tubes. And after statistical analysis, we found that females had larger membranes than males. The reason may be due to the lower hematocrit values in females, which may affect the plasma layer. However, centrifugation also influenced, because the speed with LPRF is spinning is more compared to APRF. Because of that, we got little amount of APRF compared to LPRF, and volume amount of PRF we got was more or less same, but with the antibiotic also there was no significant changes. We proceeded on with the degradation property of all PRF groups, and the objective was to compare the degradation properties of LPRF and APRF plus with and without antibiotics. And to my knowledge, this is the first study to compare the degradation rates of all these PRFs. The study design is we collected blood from 3 healthy volunteers, and we used a stagnant method for degradation. And the PRF membranes were incubated at a pH of 7.4 at 37 degrees Celsius, and initial weight was recorded using a weighing scale, and measured every 24 hours until complete degradation is obtained, and then the membranes were washed, dried and reweighed again every time. And this is the degradation study, like where we found there was complete degradation of all the PRF with and without antibiotics at the end of 5th day. However, with gentamicin alone, there was degradation present. The PRF didn't degrade even after 5th day. So, coming to the next main part of the study, like in vitro, that is antimicrobial properties of these PRF. The background is like the studies have found that plain PRF lacks antimicrobial activity. Whenever you are going to give a systemic antibiotic, it will enhance its antibacterial effect, but incorporating biomaterials into PRF will have better outcomes. That was the background of this study. The objective I told you, to explore the antibacterial potential of APRF plus and LPRF with and without antibiotics. Here, based on the sample size, we divided the samples into 3 groups. Group 1 were systemically healthy patients, the periodontium was also healthy, and group 2 systemically compromised, that they might have some systemic disease and they require periodontal treatment, and group 3 periodontally compromised but they are systemically healthy also. So based on these 3 groups, we divided them into into their subgroups like LPRF with the antibiotics, plain LPRF and LPRF with the antibiotics, with these 3 antibiotics. Then we tested the antimicrobial properties. Actually, physical properties degradation I discussed earlier, and with this study I will discuss with the antimicrobial properties. And the microbes tested are Staph aureus and E. coli. Since Staph aureus are gram positive and E. coli for gram negative, these are Staph aureus are the early colonizers followed by the gram negative bacteria. So we isolated E. coli in this study, and the key consideration is, like as I told you, based on the SEM analysis, we found that we should not increase the antibiotic concentration not more than 0.5 ml. So we stuck on to 0.5 ml with the PRF, with the blood. So after that we centrifuged it and created PRF membranes. And I told you the study groups, and I told you the methodology also. All these patients we added antibiotics after collecting blood, and we made them to produce that LPRF and APRF plus, and we measured we studied the zone of inhibition by cup plate method. This is the centrifuge I was using, and the petri dish with blood agar was used to study the zone of inhibition. And this is the zone of inhibition studied in each group with the antibiotics and without antibiotic. And you can definitely see there is a zone of inhibition seen with the antibiotic compared to plain LPRF. These are the results we got. I will discuss with the result. The key findings: the antibacterial activity, all PRF groups showed antibacterial effect. However, PRF with the antibiotic showed more zone of inhibition compared to plain PRF. APRF plus showed a larger zone of inhibition compared to LPRF, though that was not statistically significant. When we compared with the literature, PRP, PRF and IPRF all demonstrated antimicrobial effects as with our study, and however there was an study showing that this PRF is ineffective against P. gingivalis and AA. When we compared within groups for Staph aureus, there was the LPRF and amoxicillin group had most significant antibacterial effect, and with E. coli group, amoxicillin and ofoxacin had a better antibacterial effect compared to gentamicin or plain PRF. So based on this, the key takeaways in this study is PRF alone has some antibacterial effect, but when you add antibiotic, there is significant enhancement of antimicrobial effect. APRF plus may be superior due to higher leukocyte and platelet content, as I told you. This mechanism, why it is like that, is because the living cells within the fibrin matrix continuously will release antimicrobial peptides. These peptides are entrapped, gradually release fibrin, which degrades. Okay. The limitations and future directions are like we studied only RS and E. coli, and we should have isolated AA and P. gingivalis, which was difficult for us to do during the period of study, and the duration was very less, so we should have evaluated little more time, and more in vivo studies are required, but we have done only 2 studies. Going on, these are all my in vitro studies which I have done, right from the questionnaire study till the antimicrobial effects, and we will move on with the the clinical aspects of the study. The 2 studies I have done clinically, one is non-surgical and another one is surgical aspect. The non-surgical study that we compared APRF plus with antibiotic and without antibiotic. Here we used this as a local drug delivery system, where we collected blood, the same protocol, APRF with antibiotic, then we created membranes. Those membranes will be placed inside the pocket wall, okay, and used as local drug delivery, and it was examined over a period of time. From baseline to 3rd month, there was subsequent, there was phenomenal reduction in the pocket depth and improving patient compliance also. And you can see there is APRF plus ofloxacin group had more pocket depth reduction compared to plain APRF plus, and there was which was also statistically significant within groups and when comparing both the groups also. So SRP, we all know, is a non-surgical approach for for treating generalized chronic periodontitis when you don't want to do a surgical treatment. When you add a biomaterial like PRF with the antibiotics as a local drug delivery, this also improved patient compliance and also patient also recovered well. So why we choose ofloxacin here? As earlier I told you, ofloxacin was more effective against E. coli also, that is gram negative. So we selected E. coli. We selected ofloxacin here instead of amoxicillin. Because it had a superior tissue penetration and it is effective more against anaerobic bacteria, and the resistance is also very less. So the key findings from this study are it showed greater pocket depth reduction, and it usually PRF enhances collagen production, which aids in connective tissue regeneration, and APRF also promoted more immune response and antibacterial effects, which ultimately led to better healing and reducing inflammation. And even though both the groups there were significant amount of reduction of pocket depth compared to antibiotic group had more reduction when compared with the plain PRF group. So however, there is a limitation of this study is there is a lack of histological evidence, and we need an expertise to push. Initially we found it difficult to push the LPRF membrane, especially since why we selected APRF is LPRF we will get a bigger thicker membrane. APRF, because of low speed centrifugation protocol, the membrane is very thin, and so that it can be pushed inside. That's why we selected APRF plus in this study. And we need a multi-central clinical studies to validate the, all other findings, and we need a PRF long-term effect, because this study we concluded only with 3 months. We should have followed it up still more. So, coming to the surgical aspect, this is a study where we assess the antimicrobial activity of systemic administration of antibiotics before surgical procedure. So, we all know wound healing will be followed by a risk of infection. So, for that we will prescribe antibiotics post-surgical treatment. So, to prevent infection, we are going to prescribe antibiotics. Post-surgery, we expect some infection. So, to prevent that, you are going to give antibiotics systemically. So, that is one part we are dealing with daily. And the second part is LPRF. We all know that it has its regenerative potential. It has all its growth factors which also aid in healing. So, adding antibiotic into the PRF, will it aid your healing process and protect your wound structure? That was my aim of this study. So, the aim of this in vitro and clinical study is to determine if LPRF prepared after single oral dose of antibiotic will exhibit any significant antimicrobial effect over a 24 hours to 48 hours when compared with plain LPRF. The study protocol consists of two. First one is the in vitro study and then a clinical review. We conducted this in our department and ethical clearance was obtained, and we recruited 100 patients and 50 patients in each group. And in the first group we had LPRF as per Chokran's protocol. This is a plain LPRF prepared, whereas in group 2 we gave 1 gram of amoxicillin to the patients 1 hour prior to surgical protocol, be it any periodontal therapy or any implant surgery. Mostly this study we involved with implant surgery. So 1 hour before surgical procedure we gave 1 gram of amoxicillin administered before surgery, and after 1 hour we withdrew blood and then we prepared PRF membranes. The inclusion criteria were those who were intended for any implant therapy or any periodontal therapy, and the patient should not take any medication. However, exclusion criteria included pregnant nursing mothers and who received any antibiotics over the past 3 or 4 months, and patients who are allergic to medications. As I told you, the preparation, like we prepared the blood and then we made 3 membranes, one membrane, one for each microbial testing, like for zone of inhibition for Staph aureus and E. coli. The other one we used it for the surgical procedure. This is the protocol. We withdrew the blood and we centrifuged and we got PRF, made it as membrane. For the group 1 and group 2 is like with the antibiotics already in the patient's blood. We took that blood and then made PRF membranes. And then the next step was the microbial culture. We prepared that Staph aureus and E. coli culture. In that we inoculated these PRF membranes and incubated it over a period of time, 24 hours, and then zone of inhibition was measured. And in group 1, we found that the zone of inhibition was present with plain LPRF. There was zone of inhibition that we have seen in the in vitro earlier studies also. Here also we got the same. Whereas in group 2, we systemically administered antibiotics group, we had a better zone of inhibition compared to group 1. And clinically, this is about the in vitro part. The clinical assessment was done using Landry Wound Healing Index, where we assessed the tissue color, response to touch, marginality of incision line, extent of the area, and in both the groups, LPRF and LPRF plus antibiotic group. And this was assessed in the first week and the second week. These are some of the clinical scenarios. When the group 1, we selected patients who are planned for implant. And this is a socket preservation case, failed endodontic treatment. Immediately we removed and we used PRF with bone graft, plain PRF, and you can see the amount of healing with plain PRF. This is the second case where again a failed endodontic treatment, there is a dehiscence present, so we have to combine a regenerative procedure. In that procedure we are going to give LPRF also. In group 2, the same socket preservation. This is my colleague who had a failed endodontic treatment, which was, you can see there was absolutely collapse of the buccal bone, and we mixed antibiotic prior and then took the PRF and mixed with, we didn't use bone graft, we just simply placed that PRF into the site. And this is another failed endodontic treatment. Where we removed that root and then we placed implant, and in this case instead of placing PRF as a membrane, we minced that PRF and mixed it with antibiotic and then placed into the jumping space and then covered one more membrane over the surface. In this patient we prepared more than 4 to 5 membranes other than your microbiological study. This was the end result. This is another case. This is biofunctionalization of the PRF, where instead of placing PRF into the site or placing over the site as an antimicrobial agent, we coated that PRF membrane over the implant so that it will also help in better antimicrobial property at the site of osteotomy. So this is the end result. So we did a statistical analysis, and there was a zone of inhibition, as we saw directly. There was zone of inhibition more in E. coli group compared to Staph aureus. When we compared both the groups, in group 2, I mean with the antibiotic group had more better zone of inhibition compared to other group. So the zone of, I told you earlier, the zone of inhibition was found to be significantly higher with E. coli in both the groups. Comparing the healing index, like when we compared, the initial healing with the antibiotic was much better, the index was higher score, whereas with the plain PRF it was very less. As during the subsequent week, both the groups had similar healing. Coming to the discussion, the aim of the present study was to determine whether PRF prepared after systemic administration has any influence on the healing properties. Based on this study, the LPRF prepared after systemic administration showed measurable antimicrobial activity that I showed you, and this suggests that LPRF will be concentrated due to its LPRF will have the antibiotics concentrated because of its distinct structure and fibrin network that we have studied with the SEM analysis. And this is in support with the study by Baker et al., where he found with PRP and Staph aureus and E. coli. Instead of adding antibiotics directly to the collected blood, we used systemic administration and then used that PRF during the process of preparing LPRF. And this study actually indicates that antibiotics incorporated will be active for another 24 hours. Since the initial healing takes place for the first 24 to 48 hours, the initial response with the antibiotics will be better for increased infection control. And using this type of method will actually improve patient compliance also and better healing also. And during clinical examination, we found that, as I told you, LPRF plain group had lesser healing compared to with the antibiotics during the first week. However, during the second week, both had a similar effect. This may be due to that initial action of those antibiotics at that time, and after the effect regressed, it came back to its normal level. And moreover, the PRF degradation we studied was up to 5 days only. So maybe due to those first few days, we had those better healing compared to the second week. During the process, we also come across with some complications. This is in group 1, we had a swelling and infraorbital edema and ecchymosis. This does not relate with any LPRF what we have used, but this may be due to the extensive reflection of the flap, which might have also caused hematoma in that region. This was the second case I told you that there was a dehiscence present. In group 2 also we had some complications where we used biofunctionalization of the PRF, where we coated that implant with the PRF membrane and then inserted into the osteotomy site. This patient actually reported the very next day saying that he's my brother. So he reported that he had some pain in that, but I told it will get subsided. But after 4th day, he couldn't resist. Like it was like there was red swelling present that we assumed that it might be due to allergic reaction of those antibiotic incorporated PRF, which would have created a localized reaction. And it subsided immediately after giving cetirizine and steroid for a period of 4 to 5 days. And this is also healing after 30th day. So further research is required to comprehend the impact of preoperative antibiotics on LPRF clinical behavior. However, the effects of PRF antibiotic use on the antimicrobial properties, wound healing and tissue regeneration during surgical procedure should be the focus of research in future. Within limitation of the study, I could say that there was comparable zone of inhibition in both the groups, and E. coli group had more zone of inhibition. And definitely this incorporation of antibiotic with PRF will have increased antimicrobial activity and also have better healing compared to without antibiotic incorporated PRF. So actually this was the study I presented in Thaimugambigai conference, which I won first prize. These are all the various studies I have done as part of my PhD studies. With this basis, I had explored into different clinical aspects of our dentistry, where I have used this antibiotic incorporated PRF into various clinical situations. First one, extraction socket, as I showed you earlier. Socket preservation can be done with plain PRF also. There are studies showing that a lot of regeneration can happen immediately with the LPRF, plain LPRF. Whereas here we use PRF with antibiotics, had better healing with the different clinical scenarios. And this is the same my colleague, where we removed his teeth and immediately we minced with the PRF with the antibiotic and then placed into the extraction socket. And this is the healing you can appreciate after 2 weeks. And we can use, you can also, there are studies showing that PRF can be used in impacted site, where we, after removal of impacted tooth, we can place PRF into the defect. Here we used antibacterial, antibiotic incorporated PRF into that extracted site along with the regenerative material BioOS, and we had excellent result with this also. Coming to regeneration part, any biomaterial will be effective if you are not going to do an open debridement, and we can with PRF, if used alone, when compared with antibiotic and PRF and biomaterial, had better effect than when you are using PRF alone. So this is a clinical scenario where there was an intrabony defect which was filled with antibiotic incorporated PRF and bone graft, and this is a final scenario. And one more attempt was done with my PG, where we did an micro needling with IPRF alone and antibiotic incorporated PRF, and we found that there was a thicker membrane with antibiotic group, but yet to finish this study. Comparing with the furcation defects, you all know furcation, when the furcation is involved, there will be much more infectious elements present below the pocket. So as we go more deeper and deeper, you need better local delivery of the drug. So when you use a PRF incorporated antibiotic along with your regenerative material, there will be a better healing potential and also better outcome of that clinical scenario. And orthodontics also, nowadays they are using PRF for faster movement of space closure. So there was a study where we used plain PRF in one side, that is IPRF. The other side we used IPRF with antibiotic, this side, where immediately after extraction, in order to prevent any infection into that extracted site, we incorporated antibiotic into the IPRF and then placed that IPRF. You can see that a faster movement of tooth because of that IPRF and better healing with that antibiotic group. In endodontics also we can use like a periapical surgery where there is an infection at the periapical region, and in that region our systemic antibiotics will not go there and there won't be any sufficient amount of antibiotic at that site. So those sites you can mix PRF with the antibiotic and your regenerative material, and then you can close that site. An implant we can place that, as I told you earlier also, and have better healing in soft tissue. We can see the amount of soft tissue gain with the PRF and antibiotics. This is the final case, and we can use it in sinus lift procedure also, where you can use as an locally delivered platelet rich fibrin with the antibiotic at the surgical site, so that initial healing will be better compared to without using any PRF or plain PRF. This is a clinical scenario where we placed antibiotic infused PRF and checked the stability. Initially we got more than 86 in ISQ values, and this is one full case where we have used PRF can be used in facial aesthetics also. We can say nowadays in all beauty parlors they are now injecting IPRF into the facial structures like cheekbones, chins and everything to post tanning or something. So we can use antibiotic incorporated PRF to prevent such acne or pimples that which causes infection on the cheeks for young girls. And this PRF can also be used for nowadays we are using for hair fall also. This is my my hair, where I had dermatitis. You can see there is a white patch which led to fall of hair. We had a study in our surgery department where they are comparing plain IPRF and other PRP. So I told to incorporate antibiotic and then use IPRF into my scalp, and actually the dermatitis actually subsided, but again it came back. This is a full case scenario where we used PRF in two different situations. There was a failed endodontic treatment in 3-6, which led to removal of that tooth. Then we incorporated LPRF with the antibiotic and we placed it in the socket and then closed after 45 days. Since PRF has better healing potential, instead of waiting for 2 or 3 months, we can go ahead with the early placement of implant. And this is the healing we got after placing the PRF. You can see that still the extraction socket is healing. So in order to prevent further infection with to happen, we all again incorporated PRF during this procedure also. And this time we used as a shield with healing abutment. So what they call that as Ponko technique, where we fixed that PRF membrane with the healing abutment, and then we used that to cover that socket area also, and we placed some more PRF membrane also over the area and closed. These are the clinical aspects I experimented after my thesis, and based on those things I would like to conclude, like based on the SEM analysis and structural finding, even though they differed in distribution and fiber density, antibiotic addition resulted in a denser fibrin network which will help in sustained drug release. And in periodontal therapy, it enhanced antimicrobial activity, especially when it combined with antibiotics. And there was an LPRF had a greater inhibition with E. coli, and APRF plus was more effective against the initial colonizer. PRF showed stronger antimicrobial activity in systemically compromised patients, where we divided those groups into 3 where we could find that. And periodontitis and systemic diseases did not affect the PRF formation or either its length or volume. And physical and degradation property, APRF membranes were comparatively longer, but they are very thinner, and whereas LPRF were thicker, and females had larger PRF membranes, and LPRF degraded slowly compared to APRF, and antibiotic incorporated had longer degradation time. As I showed you, the gentamicin didn't even degrade after 5 days. And coming to the clinical studies, their systemic antibiotic administration surely enhanced LPRF's antimicrobial efficacy, and ofloxacin incorporated LPRF as LPRF as local drug delivery also improved the clinical scenario. Coming to the strengths of my study, first one is a comprehensive evaluation. Like, this is the first study to evaluate or compare antimicrobial properties of LPRF and APRF plus. We examined both systemic and local antibiotic incorporation into PRF, that is systemically administered, then took PRF, and locally also we applied that. And we compared PRF properties among healthy patients and also diseased patients also. And coming to the relevance of antimicrobials in clinical situations, we demonstrated that enhanced antimicrobial activity when used with antibiotics. And this is the first study to show that antimicrobial effects against E. coli, and PRF obtained after systemic administration demonstrated excellent post-operative healing and enhanced patient-centered outcomes also. In non-surgical therapy also, we had a better outcome. Comparing the physical and structural analysis, when compared, SEM analysis provided us the insight, but there are not much studies which had SEM analysis where we could see the structural differences. And coming to the clinical applications, as I told you, it can be used as local drug delivery system and also during surgical procedure to prevent any infection. Coming to the limitations of my study, more or less we had a smaller sample size. We need a multi-center trial also. The shorter follow-up period in that non-surgical therapy, we could have done a little more longer period of time. And methodological consideration, we used a fixed angle centrifuge. Fixed angle centrifuge is the commonly present in India. We should have also compared it with the horizontal angle centrifuge. Horizontal angle centrifuge is not available in India. It's like only limited people are having, around 2 to 3 people are having in India. Coming to the next methodological constraints, the lack of histological evidence in clinical study, and it is more technique sensitive when I tell about the local drug delivery system. And future direction is like, when we found that antibiotics can be held with PRF, it can be used to treat peri-implantitis also, and we can customize for each patient profile also, and it can be used for wound healing biomarkers also can be used, and we can optimize the antibiotic loading also, and the regenerative potential also increased. In fact, that is a coincidence or this thing, we couldn't analyze that, but the regenerative potential was more predictive. And as I told you, we took forward into the our study into, like, we would like to compare it with the horizontal angle centrifugation. One of my friend is in Theni. He's a general surgeon. He's having this horizontal centrifuge. So we had requested him, and we utilized this PRF with using this horizontal centrifuge. What we are all using is Chokran's principle of using fixed angle centrifuge, where the rotor will be at a 45-degree angulation, whereas in horizontal centrifuge, the rotor will rotate at a 90-degree angulation, and compared to 45-degree, this will be the 90-degree angulation. So what is the difference? Whenever you give a force, or when it is rotating, it is giving a force, that is called the G force. That force will increase on the walls of the test tube. So what will happen, that whenever whenever you are going to centrifuge, it will rotate at an RPM. The cells will go and hit on the walls of the opposite wall of the test tube. So what will happen? Most of the cells will get shattered. So will not get that much amount of cells in fixed angle centrifuge. Whereas in horizontal angle centrifuge, it will not go and hit the opposite wall of the test tube. It will be rotated within that test tube, so that there won't be any shattering of that cells. This is what that Miron has proposed. This Miron and Chokran, they still have a Cold War, and they still are fighting for their different types. When Chokran says it's LPRF, IPRF and APRF, and Miron says it's liquid PRF, bio PRF and HPRF or CPRF, whatever name he has kept, it's different compared to Chokran. Chokran used fixed angle centrifugation, where he has given his own classification, whereas Miron has given his own classification. In fact, he has introduced biocool device, where you keep your PRF after centrifuge into that biocool device, then use that PRF also. That is beyond the scope of my study. So since there was a limitation that we should have compared it with the horizontal centrifuge, so we used this. So we used this horizontal centrifuge. We can see that in that picture, you can see the one wall of the test tube. You can see there is a red marking, that is shattering of that RBCs and other cells on the walls of the test tube while spinning. Whereas in horizontal, there is no difference. Like, I had a good plasma, and this is what we obtained in the horizontal centrifuge. And that side, you can see there is an angulation at which your PRF will form. This is the angulation. You can see here, there is an angulation will form. Here it will be there is a horizontal level. That's the main difference between horizontal centrifugation and your fixed angle centrifugation. Comparing the cells, as I told you, more evenly spread cells will be present in horizontal centrifugation compared to your fixed angle centrifugation. And these are some of the differences. As I have told you already, these are the differences. And we did one case with this horizontal centrifugation. That centrifuge, what he calls is that bio-PRF centrifuged machine. And same like the last study, systemically healthy patient we selected, and who is planned for implant therapy, and we gave 1 gram of amoxicillin prior to surgical procedure. Then we collected PRF, and we gave one set to the microbiologic analysis and the other set for using during our surgical procedure. This is what we got. And for the microbiological examination, we found that there was a definite zone of inhibition compared to in comparing both Staph aureus and E. coli. And the some analysis, we can see the fine denser fibers are present. And this is the clinical scenario where you can see the horizontal centrifuge usage. We got a PRF which we used for implant therapy. You can see that in the last picture, that excellent soft tissue healing post using horizontal centrifuge with the antibiotic. So what are the future perspective from this study? We can say that TMJ arthrosis, like we can use several treatment which will be injecting steroid or everything inside your joint space, you can use PRF as a carrier, and you can either take antibiotic or prolonged dosage of medicines into that PRF, and then you can inject into the TMJ. And another thing I would like to add here is I suffered from tennis elbow. So in that, when the doctor told to inject steroid into the site, I asked him to inject PRF with antibiotic. It also worked. Now I have pain, but not that much of pain. And what are the benefits for the public? There will be a faster healing and recovery, and there is a reduced need for systemic antibiotics. There will be lower risk for post-operative infection, and it is more cost effective and biocompatible, and minimization of surgical complications, and there are improved clinical outcomes with high risk patients, and we can use for advanced periodontal or implant therapy. With this, I conclude my presentation. I would like to thank the management of this institute, my guide, my external expert, Dr. Anita, and my university faculty who was very helpful during my study period. I should also acknowledge the help of my co-PhD. It is her who pushed me through. I will be very lenient or very she will be very strict on certain things, and she will push me also to do. And I should thank Dr. Aparna. She was my PG student, now working in Ramchandra University as senior lecturer. She was the backbone of most of my studies, where she helped me. And Dr. Gokul Nivas, he was my physical help whenever I couldn't travel because of my daughter's studies or whatever it is. So he used to travel here and submit everything. I should thank these three people, without whom it will be very difficult. But not the least, I would like to thank my daughter. All that I am and all that I strive for, and this thesis is for her. Thank you all.
Nice presentation, Dr. Balaji. Quite extensive. There are just a few things I would like to ask. Actually, when I was going through your literature, you have mentioned there are three things which affect the structure. One is the time, and there was something called as relative centrifugation force. I was not very
So that is the centrifugation force that is present inbuilt into the centrifuge machine itself. It has an effect. So whenever you are going to do a faster spin, like in LPRF, there will be faster spin, that force will be more. When you are going to lower speed, the force will be very less. See, suppose you are going to APRF, the force is very less, to around 200 grams. Whereas for LPRF, it is more than 700 grams. When you increase that force, you will have the cells being shattered, as I showed you with the horizontal centrifugation also. So the same thing will happen in fixed angle also. When you increase the speed of the centrifuge, and the force will also increase, that is called the G force, which will directly affect the cells that is present in the...
Does it affect the texture or the distribution of the cells?
Distribution of the cells is, it will affect.
Okay. And between LPRF and APRF, the structural difference you said there is, like the distribution of cells is different. How does it affect in clinical scenario? Does it have a difference because of that?
There is a difference, like LPRF membranes are very thick, whereas APRF it is very thin. So whenever you are going to use it as a membrane, then you can go ahead with the LPRF, whereas in APRF it is very thin, and you can mince it and then you can use it.
Okay. And because of this, because of the distribution of cells within the membrane, is there any difference in how the properties are different? Like, for example, the antimicrobial property duration or the release of the antimicrobial, is it different because of that structural difference?
Because of structural difference, we didn't find that any, we didn't see that aspect. We saw that it didn't, no, it was not.
No. Okay. Okay. The other thing is you did uh, use additional antibiotics to study the antimicrobial effect of the PRF. Plain PRF, all the groups,
They have actually platelets by itself or antimicrobial. They have antimicrobial effect. To enhance its activity, we are adding antimicrobial.
did compare it with a plain.
Yeah. All the studies are compared with plain PRF.
And like for example, the physical properties, the volume and length were not shown, but there was a difference in the degradation time, especially gentamicin was very low. So does that incorporation affect the degradation time, in what ways?
No, probably the gentamicin group would have got more time for degradation. That is maybe due to the addition of those antibiotic also. The antibiotic would have interfered with the degradation property also. The thing is, each and every time, this was not done in our college. It was done in another microbiological setup, where every time we have to go remove that PRF, wash it, and we have to keep it again, and then weigh again, then again we have to subtract, and we have to do that calculation. So during that process also there might have some difference.
Has this been shown like this, like gentamicin?
No, what antibiotics we have used, amoxicillin, ofloxacin, and gentamicin. Amoxicillin has been shown in literature, whereas these two are not shown.
And similarly, in the effect of on all the three groups, like your healthy, periodontally compromised but systemically healthy, and the systemically compromised and systemically healthy, the third group showed more PRF. Like, what would be your support for that? Like, why is it that it's most effective in those? You have to see, yeah. And also, even in along with females, even in elderly people, the membranes were larger. Yes.
So that we didn't check that.
Okay.
We were more concerned on whether females are.
Okay, and does that have a difference in the antimicrobial activity?
No, it didn't have.
No. You even said that even systemic diseases do not have an effect, right? And some more things. In this, the degradations method which you studied, are there any other ways to study degradation?
Yeah, there are several other ways. There is one way called some one petri dish. They will usually it will spin by itself, and we have to sit there and we have to see that. And each time how much one person should be specifically, we have to sit there and watch that. So because of that, we didn't select that method.
Okay, in the clinical scenario, you had given systemic antibiotic before, 1 hour before, and then withdrew the blood. Have you like is there a difference that if you don't do like that and incorporate the antibiotic in the PRF membrane separately, like how you did for the others, would there be any difference? Because like you said, 0.5 mg is the ideal thing. So when you give it systemically, how do we get that? Like, is it going to affect? Because one of the studies based on which you said that, they said that if it is more, it is not that ideal. So how will we like kind of make sure that systemically how much should be given so that around this much?
So actually we had a parent article where it's not a parent article, it's a case report. Only case report is present, where they have used 1 gram of amoxicillin and they have showed what we have obtained. So based on that study, we proposed this study that we will give systemically 1 hour before the surgical procedure, and then we take the PRF. Because the antibiotic peak volume will come immediately, like it will take some time, from 45 minutes to 1 hour. At that time, if you take that PRF, it will be present everywhere. So
It is there for
24 hours post surgical.
Yeah. And this antibacterial effect which the PRF has, if you give it added, does it have any reported time range as to how long is it effective, or is it like, have they studied how long that antimicrobial effect of the PRF is present?
Actually, it should be based on the calculation of the degradation time. The degradation time we found is up to 5 to 7 days, not more than that. So till that time only you will have that effect of PRF on that local site. The antibiotics will stay only for around 48 hours max. After that it will reduce. The initial healing and the initial this thing will be better when you incorporate your antibiotics.
Okay. In the clinical things, you have you propose that the LPRF, because of the thickness and stability, should be used more like if it is used alone, right? And the APRF should
be used for local drug delivery because it is very thin and loosely arranged and it can pack it easily inside the sulcus, whereas in surgical part, no, you can reflect everything and you can place that membrane at the site. So it will be more effective compared to APRF. APRF will be a thin membrane. What we felt was like it will get dislodged or
between this difference in thickness, there is no difference in the antimicrobial.
Similar.
Congratulations for completing your research work. And out of there are many antibiotics available. Why did you choose these three?
Because ma'am, amoxicillin is broad spectrum and it's more effective against the initial colonizers. Ofloxacin we selected why? Because it will be more effective against the gram-negative bacteria. Already studies are there with the metro and other tetracycline. So we wanted to add one more drug. So we thought we will use ofloxacin. Gentamicin was just an addition, but it also gave some. But our primary focus was on amoxicillin and ofloxacin.
So regarding PRF, you selected APRF plus. What any special?
No, the APRF plus growth factors release the number of growth factors released in APRF plus and LPRF also similar. So because of different APRF, if you have selected another APRF or another PRF with the different regenerative potential, then that might also interfere with that. So we wanted to nullify those effects so that regenerative potential should be the same, only the antibiotic effect should make the difference. So that way we selected APRF plus. One is a low speed centrifugation, another one is a regular faster spin.
So what are all the recommendations you want to convey to the clinicians based on your studies?
Based on my study, I showed you my experience with various clinical scenarios. Whenever you are going for any surgical aspect, it's better to incorporate antibiotic either during spinning or give antibiotic prior to surgical procedure and then take that PRF and use that in that surgical site. That will be much more better way of giving patient a good outcome.
Any questions?
Did you add before or after centrifugation?
Before.
And did you check the effect on the release benefits of the growth factors? Is there an influence?
Growth factor release we didn't check, but we were more concerned with the antibiotic only. So it's already proved, no? It's now. So now we are doing a study comparing what type of growth factors are being released depending on, as she told, like the G-force, different G-force, and how much growth factors are going to be released, that we are now proposed with our PG. So we will be doing in near future. If get the opportunity, I can show that also.
So at the end of the presentation, Dr. Balaji has successfully defended his all the questions very well, and the dissertation also was done, like it was really extensive. So I recommend that he be conferred the PhD for the particular topic.